All right. A very good evening, everyone. Welcome to ISG Masterclass. This is the seventh edition of the ongoing masterclass during COVID time. And I think we'll remember this time with a lot of memories in our mind. So the last lecture by Dr. S.K. Sarin, I'm sure all of you would have enjoyed very much. And almost 2,000 people saw him live on the masterclass platform and about a few hundred on Facebook. And he also had, many people have watched this lecture on Facebook Live later also. As you are aware that we are putting all these recordings of all these great lectures on ISG website and also on the Facebook. So you can, if you have missed any of these lectures, you might go there and watch these lectures again. So now we have a next lecture, and with this very important topic, that is acute kidney injury in those patients who have a liver cirrhosis. And all of us know that this is a really, really important topic, not easy to understand. There are a number of new definitions, new classifications, and how do you treat these patients. And we have, for that, one of the most well-known person who have worked extensively in this field, Dr. Rakhi Maiwall. You know that she is a professor of gastroenterology, hepatology at ILBS New Delhi, and she is very well known. So she will speak to us on this topic. And we also have invited Dr. C.E. Epan. He is head of gastroenterology and hepatology at CMC Vellore, very well known hepatologist in our country, and he will moderate this session. Few more things before I hand over to Dr. Saraswat to take this further, that we have sent a questionnaire to all of you to seek your opinion on the quality of these webinars, the audio's quality, the video quality, the content of talks, the selection of topics, and if you want to continue these webinars in the future also after we come out of this lockdown period. So please do respond to this questionnaire. We will send this questionnaire again today to you after we complete the talk by Dr. Rakhi Maiwall. With this, may I invite Dr. Vivek Saraswat, who is president of Indian Society of Gastroenterology, to speak to you, and then we go to lecture by Dr. Rakhi Maiwall. Dr. Saraswat, please.
Thank you, Dr. Govind. Good evening, everyone who's logged on. It's a great pleasure to welcome you all once again to this edition of the ISG Masterclass. As Dr. Govind has spoken to you, I think this is an ongoing series of webinars that ISG has organized. And looking at the very positive response that we have got hitherto, we are planning to continue this series beyond the advertised date of lectures, and add on or the additional sessions or the additional format of what will be the sessions after the last one in this series. The 12 lectures that have been planned are completed, is something that we'll send out, and that is why we are looking forward to your feedback on questionnaires. How did you find these sessions? Which are the topics that you are further interested in listening to in this format, and so on. So as Dr. Govind has told you regarding acute kidney injury in patients with liver cirrhosis, Professor Rakhi Maiwall will be talking to you. Rakhi is a rising star on the hepatology firmament in India. Although she's a professor already, we have known her for the last 8 or 10 years, and a steady rise. I think it was started in Kanpur, I think, then via Vellore, now at ILBS in Delhi, and a very impressive set of series of publications. Not only is she concentrating on acute and chronic liver failure, but within that, again, on the subset of acute kidney injury in them, and an impressive CV has been built up and a body of work that she has done. So we will be looking forward to hearing to her about on this topic. Now, as you all know, during this whole interaction, you are welcome to use the chat box and send in your questions. we'll be breaking at after about 15 or 20 minutes or so into Dr. Maiwall's talk for taking the first set of questions, which Professor Eapen will moderate. Thereafter, once the talk is concluded, whatever questions the time permits, the next 20, between 15 or 20 minutes, we'll be myself, Dr. Govind, and Dr. Eapen will be putting these questions to Dr. Maiwall for her response. And the additional queries, as usual, the answers from the expert, we will be channelized to you through the ISG Secretariat. With this, I also welcome those of you who are attending. I think almost every session we are getting between 120 to 150 people attending from Bangladesh. Last session we had about 30 odd people attending from Myanmar, and small numbers also, about 30 or 40 from Nepal, and a few from Sri Lanka and Pakistan are also logging into this series. So I welcome all of you, and with this I would request Dr. Rakhi Maiwall to kindly begin her presentation. Dr. Rakhi, please.
Thank you, sir, Saraswat sir, Govind sir, for considering me and giving me an opportunity to present this talk on acute kidney injury in liver cirrhosis. And I'm very thankful for the kind introduction. And I'm also very thankful for choosing Dr. Eapen, who's also been my teacher and mentor at Vellore, as a moderator of this session. So I'll start off. So I'll start my talk actually by starting a real life case scenario, because this will make us easy to understand the different concepts that we'll be discussing with respect to diagnosing and managing AKI in a patient with liver disease. So this was a 51 years old gentleman. He was non-alcoholic without any comorbidities, who came to us at ILBS in the January. And outside, he was already having a diagnosis of portal hypertension. He was evaluated extensively. He had grade 2 esophageal varices. He had no history of prior variceal bleed. He had chronic liver disease, and the etiological workup had revealed a presence of hepatitis C, and he was treatment naive, and he was never been treated in the past for the same. He was decompensated with ascites, and this ascites was high SAG and low protein, consistent with portal hypertension. He also was diagnosed with right moderate pleural effusion, which was consistent with hepatic hydrothorax. He had jaundice, and also he had prior 2 episodes of AKI, from which he had recovered. The first episode was diuretic related, and the second episode he required hospital admission for AKI HRS, and he required albumin and terlipressin. So he presented to us with worsening abdominal distension in the last 2 months, and which was requiring repeated large volume paracentesis, and he also had bilateral pedal edema. Now, if you look at the physical examination, it was unremarkable, excepting what I wanted to highlight was a low mean arterial pressure, which we can see here. His blood pressure was systolic of 106, and the diastolic BP was just 58. Apart from that, he had mild pallor, he had bilateral pedal edema, which was symmetric. And on abdominal examination, he had a palpable spleen, and he had significant free fluid and ascites. So his blood parameters had shown mild anemia. His INR was 1.5, his bilirubin was 1.6, albumin was lower side, 2.1. His total core hepatitis B was negative, and HCV RNA was 2 log. So what we are going to concentrate is here on the kidney function test. So we had 2 sets of kidney function tests which were available. So the first visit itself, his kidney function test had revealed a urea of 88 and a creatinine of 1.22. And on February, it was when he got admitted for the same, his urea was 109 and the creatinine had gone up to 1.82. The imaging of the abdomen was consistent with features of chronic liver disease and portal hypertension. There was gross free fluid, and it showed normal sized kidneys. So we start from here, and we start discussing about how do we start going about assessment of renal functions. Then we'll be discussing about the spectrum of AKI, the pathophysiologic basis, and finally we'll be discussing the diagnostic algorithm and the treatment options that are available. So most important for us is to have a good assessment of renal dysfunction. And like once you see a deranged liver function test, the first thing which clicks your mind is how long is the duration of the disease, and does this patient already has significant liver disease? The same with the kidneys also applies. So once you see a deranged kidney function test, it is very, very important for us to see whether this patient is already having some form of chronic kidney damage. And in liver patients, we will discuss both the chronic kidney damage in these patients could be both liver related or liver unrelated. You can have an AKI on a background normal kidneys, which is much more common, and you can have AKI on CKD. And another new emerging entity is acute kidney disease, which also we would be discussing. So this is what you can actually encounter while you see patients in your patients with liver disease in outpatient or inpatient. So they may have an AKI on a background normal kidneys versus they may have a compromised kidney function. So then if we consider this and we go on, so how do we grade the renal dysfunction? So it's very, very important for us that we know that how long this injury has been occurring. So there is how we divide these patients into three sets. The first is the acute kidney injury. The second set is the patients where there is a subacute kidney damage, where we call it as acute kidney disease. And the third is obviously the chronic kidney damage, where the patient has already developed end-stage chronic kidney disease. So how do we define these entities? So you may be picking up these patients early on in the course. So you should be very familiar with the definitions. So for acute kidney injury, it is defined that there should be an increase in serum creatinine of more than or equal to 0.3 mg per dl. The timeline for the increase or the elevation in serum creatinine has been mentioned as it should happen within a span of 48 hours. And we have to see that from the available serum creatinine of the patient. Or if you have a baseline value of serum creatinine, you have to see that it has risen above 50% from the baseline in the last 7 days. And now we are also considering the urine output criteria. So if you have a patient which is catheterized, the patient is there in the intensive care unit, you can see that if the urine output is below 0.5 ml per kg per body weight of the person for more than or equal to 6 hours, this actually qualifies for the diagnosis of acute kidney injury. Chronic kidney disease, we all know, is abnormalities in kidney structure or function, and the functional abnormalities are detected by assessing the GFR, and the GFR, if it is less than 60 ml and it persists for more than 3 months duration, this qualifies for the diagnosis of chronic kidney disease. So what is acute kidney disease? Acute kidney disease is somewhere lying, a patient lies, it has not gone towards chronic kidney damage. The patient has a prolonged AKI. There is a significant reduction of GFR of about more than 35% from the baseline. And the patient is having some form of structural kidney damage, but has not met the criteria of 3 months, which qualifies for the diagnosis of chronic kidney disease.
Dr. Rakhi,
Yeah.
Can you use your mouse pointer in between your slides?
Okay, sir.
To make the attention media.
Okay, sir. So we go on to the assessment, and then now we'll discuss why is it relevant for us to discuss and identify chronic kidney disease in our patients with liver disease. So it's an important diagram here to suggest that in a patient with liver disease, you have risk factors for decompensated cirrhosis. These patients get AKI, and now it has been shown that this AKI can itself lead to CKD. This was well established for patients with non-liver patients, but now it has also been proven the same happens in patients of chronic liver disease. Now, if your patient has risk factors, for instance, a patient has metabolic syndrome, diabetes, obesity, all these are risk factors for chronic kidney disease. At the same time, these factors are also responsible for causing acute kidney injury. Now, patient has both risk factors for AKI and CKD. So these risk factors, so this patient will have a faster progression to chronic kidney disease, because you have risk factors for liver disease which are driving AKI. You have risk factors of AKI itself causing CKD. And the most vicious loop is where your patient has risk factors which lead to both AKI and CKD. AKI is leading to CKD, and then the CKD itself starts leading to development of more frequent AKI in these patients. So this is very, very important for us to know. And that's why, because CKD leads to poor outcomes of AKI, the recovery chances of these patients gets poorer. These patients go on to develop late chronic kidney disease, permanent kidney damage, the requirement of dialysis could be there. And most of the time, these patients have more problems and complications due to cardiovascular diseases. So it's very, very important for us to have a good assessment of the kidney, so as that we should not be missing chronic kidney disease in patients with liver disease, especially with the advent of metabolic syndrome and non-alcoholic fatty liver disease. It becomes very, very important for us to understand and know, and do not miss this in your patient. Now, this was an earlier report of kidney biopsies in patients with liver disease, this was a French study where they showed that in patients with decompensated cirrhosis who were awaiting liver transplant, when they biopsied all such patients, and this was very interesting, these patients did not have anything to suggest a requirement of a simultaneous liver kidney transplant. They were planned for liver transplant alone. And when they biopsied all these patients, it was very interestingly, they showed that almost 60% of these patients of liver disease had some or the other form of structural AKI. So structural AKI is very, very different concept. So initially we used to think that HRS is a functional AKI and there is no damage to the kidneys, which happens in HRS, but also this concept has been changing. And now more and more people are recognizing that HRS itself can lead to structural kidney damage in patients with liver cirrhosis. So what they found in this study was, amongst these structural lesions, they found 82% of these lesions were due to glomerular involvement, and the IgA nephropathy was the most common, followed by diabetes and MPGN. And non-glomerular lesions, that is diseases of the acute or the chronic tubular interstitial, nephritis, the vascular changes that were seen. So all these changes were also seen in almost 50% of these biopsied patients. So what could be the spectrum of chronic kidney disease in patients with cirrhosis? So you have non-specific diseases, like I already mentioned, components of metabolic syndrome. Age is another very important factor, because with aging, there is a decline in GFR, which is there. And specific diseases which are relevant for patients, like in our patient, the patient has hepatitis C, hepatitis B. All these infections can itself lead to glomerulopathies, and they can cause structural kidney injury. And now HRS2, which we used to call, is now being labeled as HRS and AKI, is another very important cause of structural kidney damage and development of chronic kidney disease. So these patients can actually behave like chronic kidney disease patients. So it's very, very important for us to understand these new and evolving concepts in patients with cirrhosis. So how do you do the initial assessment of CKD? Because we know that kidney biopsy is the gold standard, but we can almost never use this, and you have a lot of challenges doing a routine kidney biopsy in liver patients. So what do you do? So you go with the functional and the non-invasive criteria. So it's very easy to do a GFR estimation. Again, the gold standard will be measured GFR, but we cannot do that practically in every patient, and clinically it is not available. So you go by the estimated GFR, which we'll be discussing a little bit in detail. We have to rely on the urine analysis, which is a very, very important modality. And obviously an imaging, if the imaging is consistent with features of chronic kidney disease, we have established diagnosis and we do not have to worry about doing a kidney biopsy. So as an initial assessment, what is suggested is that now you start recording a patient. You should have a recording for baseline serum creatinine for every liver patient that you see for the first time. Go back into the records, see in the last 3 months whether the kidney functions have been stable. If they were stable, what was the lowest value of serum creatinine? Or if the patient has been having repeated episodes of AKI in the last 3 months, you need to have a record of all this. It's also important that even though it is not there in the guidelines, but it is also important that we should be recording a baseline urine analysis of such patients, and also an estimated GFR if at all it is possible. Now, how do we estimate the GFR? So we have the gold standard test, and I do not have time to go into the details of that. So what is more relevant for us in clinical practice is to follow one of the GFR estimating equations, what is recommended by the international experts for liver cirrhotic patients. These are specific patients for, these are equations that have been developed specifically looking at the problems and challenges in liver patients. So they have low albumin, they have ascites, which actually does not reveal, and most of the other GFR equations ideally overestimate GFR. So such equations have been developed, which can actually give us a good estimate of the renal function. In the recent times, cystatin C has emerged as a very important biomarker, and the CKD, EPI, cystatin C, and creatinine equation has also been evaluated in patients with decompensated cirrhosis, and it has been evaluated against the gold standard methods, and it shows very good results. So you can use maybe one or two equations to make a clear assessment of the kidney functions of the patient, or you can use any of the equation which is easy for you, and you can have a estimate. So you should have an estimate of the baseline kidney functions. So this is about the MDRD6 equation. It is a 6-variable equation, and it is what has been recommended, and it has been studied in patients extensively. It actually underestimates GFR. So if you're checking GFR or measuring GFR with the MDRD6, you may be underestimating, but you are not overestimating the kidney functions in these patients. And these are the 6 components. It includes the creatinine, the age, race, gender, blood urea nitrogen, and albumin. So we go back to our case. So it's important, we had 2 sets of tests available. So as I mentioned, we have to have a recording of the baseline serum creatinine. So when we looked back into his records, we found that the baseline serum creatinine of this patient in the last 3 months was 0.87, with which we calculated his GFR using this baseline value of serum creatinine and the laboratory tests that we had. And the baseline GFR for this patient was 98 in the last 3 months. So this means that despite having 2 episodes of AKI before presentation, this patient had a normal imaging, had a normal GFR and a normal baseline creatinine, which suggests that there is no evidence of chronic kidney disease in this patient. So now let's start approaching this patient as a patient of acute kidney injury. So now how do we go about approaching acute kidney injury in such patient? So we will be discussing and following this up in the 6 steps. The first will be the diagnosis of AKI, what criteria you should be following. In the second step, the most important step I feel is delineating the spectrum or the cause of AKI. In the third step, after we have done an assessment of the spectrum or the cause, we need to stage, and we need to know how severe is the AKI. And after we have staged our patient and we start the treatment protocol, it is important for us to monitor the course. And subsequently, it's very important to go and see what is the recovery like, whether the patient has recovered partially or completely. And then we'll discuss about the treatment of both HRS and non-HRS AKI. So we'll go on to the definitions. That is very, very important. I already discussed the definition of AKI, and there have been some changes in this, which we'll be discussing in a short while. But as of now, it is important that we start assessing AKI using the creatinine estimation in a span of 48 hours or a 50% increase from in the past 7 days. Then it's important for us to stage the AKI. The staging is done in 3 stages. Stage 1 is where your creatinine is elevated by 0.3, or it is 1.5 to 2-fold from the baseline. In stage 2, there is increase of more than 2 to 3-fold from the baseline. And stage 3 is actually more complex. Here you have a patient may have a 3-fold increase from the baseline. A patient may have a serum creatinine of more than 4 with an acute increase of 0.3. Or the patient may have required dialysis. So all this comes under stage 3 AKI. What is progression? Because these terms will be using subsequently in my presentation. Progression is where your patient goes from one stage to a higher stage, and this is called as progression. And similarly, vice versa, regression is where the patient goes from stage 3 to stage 2. Now, regression can be partial, where the patient has complete regression. That is, the serum creatinine reduces to almost less than 0.3 of the baseline value of serum creatinine. So you should be having a baseline available. And to assess the partial response, where the creatinine, even though the patient has regression of AKI, but the creatinine remains elevated and the patient remains does not reach the within the 0.3 limit of its baseline value. And no responses where the patient remains in the same stage and does not have any regression of the AKI. So this is important for us, again, to discuss what has been new in the definitions of HRS. There's a lot of changes in the nomenclature of HRS that we have in patients with liver cirrhosis. So what we initially used to called as HRS1, where the definition include increase in there was a rapid increase in creatinine above 2.5 or in a span of 2 weeks time. This nomenclature was changed to HRS AKI, and the revised definition of HRS AKI had removed serum creatinine from the definition because we know that there are so many difficulties in measuring serum creatinine, and it does not give us the exact measurement of serum of the kidney function derangement in these patients. And now another important thing which they have changed here is that they have incorporated urine output, because initially it was decided that the patient of liver disease are on diuretics, you do not routinely catheterize them, and it is difficult to do a timed urine collection. So you cannot, it's okay if you do not incorporate urine output. But later, the experts realized that in case you're monitoring your patient and your patient has been catheterized, and this is especially relevant in the intensive care unit, it is very, very important not to ignore urine output, because that becomes the most important factor which leads us to the diagnosis of diagnosing the AKI in the right time in these patients. The third important thing which they have changed is that initially the recommendation had included that the creatinine has to increase above 50% in a span of 7 days, but now they say that it could be 50% increase from the baseline value of outpatient creatinine. Like I mentioned, in our patient, he came to us with a creatinine of 1.8, so this qualifies as AKI. HRS2 also has a new nomenclature. So HRS2, which is usually seen in patients with refractory ascites, has now been given a revised nomenclature where it is called as HRS non-AKI, which can subsequently be subdivided as HRS AKD, where the patient has not met the 3 months duration criteria for the GFR or for the structural kidney damage that you see many a times in these patients, or if the patient has clear-cut GFR, which is less than 60 ml for more than 3 months, then he qualifies to meet the diagnosis of HRS CKD. So we go back to our case. So this was the baseline serum creatinine, and this patient has come to us with an increase in the creatinine to 1.82. So this patient has a decrease in the GFR also, and he is qualifying into the diagnosis of stage 2 AKI. And this patient, considering the advanced cirrhosis, the prior response to treatment with albumin and terlipressin, it is very, very important for us to keep a close watch on this patient. And we may not need to wait for 48 hours. And that's how we should be discussing, how we should be evaluating and see that this patient could be having an AKI HRS itself. So we go on to evaluation of the spectrum of AKI. So the spectrum of AKI in liver patients, they can have a pre-renal AKI, they can have renal or intrinsic AKI, and very less often, but it is also very important for us to rule out any features of obstructive uropathy in these patients. Now, pre-renal AKI has the best outcome, and it is the most common form of AKI, and most of the times it will have a complete resolution, and it has good outcomes. But the difficult ones are the patients where they get a volume non-responsive AKI, which is HRS AKI, or the patient gets a permanent damage or an ongoing smoldering damage of the kidneys in the form of HRS non-AKI. So while you are able to delineate the spectrum, it is very, very important for us to understand the pathophysiologic basis of AKI. So patients with cirrhosis and portal hypertension, they have increased sinusoidal pressure and increased intrahepatic pressures, because of which there is increased shear stress, there is increased release of vasodilators, which results in splanchnic and systemic vascular dilatation of the vascular beds. There is a decrease in the effective circulatory volume, and obviously this results and this manifests as decrease in the mean arterial pressure. And that's why I highlighted the significance of the patient who presented to us of having a low BP. So with this, these patients have an activation of the renin-angiotensin system. There is increase in the sympathetic nervous system. There is renal vasoconstriction. There is poor renal perfusion. And these kidneys become very, very sensitive to any smaller insult. So if there is any insult due to diuretic use, to vomitings, to any GI losses, so these patients are predisposed to get volume responsive AKI after they get into this syndrome. But what is more common and what is more challenge for us is that when you see patients with liver disease with stage 2 or 3, that is severe forms of AKI, most of the times it is always multifactorial. So it is never that. So they may be on diuretics. On top of that, they may get an infection. They may be having a background acute and chronic liver failure and systemic inflammation. And on top of that, if they get a diuretic related AKI or they get diarrhea, so they have a pre-renal insult, they may take some Ayurvedic medications. So they may have a drug insult, which is responsible for some form of structural AKI. So we should never have a tubular vision. And most of the times when we are seeing patients with liver disease, it is very important for us to consider that the patient may have multiple etiologies of AKI, especially if the patient has presented to you with severe AKI stage 2 or 3. The other important factors is the renal perfusion due to shock. So any form of hypoxia to the kidneys, that is the most common cause of causing ischemic ATN. Drugs have been implicated in causing structural damage. They can be drug-induced interstitial nephritis. Many antibiotics which we commonly use, for instance, fluoroquinolones, are known to cause interstitial nephritis to the kidney. So we should be very, very particular to evaluate all the prescription NSAIDs, paracetamol, all these drugs, antibiotic prescriptions, aminoglycosides. It is very, very important to have a thorough drug list checked, because this is another very important culprit, and this should be addressed in the initial phase of the AKI. You have to rule out an intrinsic renal disease, and that's why it was important for us to rule out all the forms of intrinsic renal disease that could be there. The component of heart in influencing the kidney damage is also very important. So most of the times the patients with liver disease, once they develop ascites, most of them will have some form of cirrhotic cardiomyopathy, and early diastolic dysfunction will be there. However, if they get a cirrhotic cardiomyopathy which is manifested by low cardiac output, again it becomes a congestive AKI in such patients. So these patients can have all forms of cardiorenal syndromes also. So evaluation of the heart also becomes very important. If you have a patient of liver disease with grade 3 ascites, this patient is at a risk of developing paracentesis-induced circulatory dysfunction and subsequent AKI. But at the same time, if this patient has tense ascites, high intra-abdominal pressures can itself compromise the venous return, and this itself can cause a compromised renal perfusion and the blood flow, and therefore paracentesis in these patients also becomes important. So you should be assessing the intra-abdominal pressures, you should be managing the fluids properly. So all this decision making and assessment of the different cause and culprits of AKI is very, very important once we start assessing patients with liver disease who have presented to us AKI. Adrenal insufficiency is also a very important syndrome that has been recognized, and it has been seen to occur much early. As respect to other patients with septic shock, patients with liver disease are known to have hepatoadrenal syndrome, which can also have its effects on the kidneys. So we go on from here in a patient, and so we have done the diagnosis of AKI. It is important for us now to identify the spectrum. So the first thing which you should be asking in your patient to evaluate the spectrum is to go for a microscopic urine analysis. And whatever causes I discussed of structural AKI can be easily got from the microscopic urine analysis. So you can differentiate and you can identify structural injury. If you get a structural injury, you can even localize with the help of urine analysis that the disease is localized to the glomerulus, the disease involves the renal tubules, the interstitium, or the intrarenal blood vessels. And again, the most important thing for us and what we encounter in our day-to-day practice is we need to identify patients of HRS AKI from ATN, because both have different management decisions have to be taken. Vasoconstrictors should not be given to ATN patients because they can further compromise the renal perfusion. So we approach the urine analysis here, and if we see the urine macroscopic analysis, we have to see the pH, the osmolarity. pH becomes very important for us if you're thinking of renal tubular acidosis, if you're thinking of nephrogenic diabetes insipidus. Even for ATN, osmolarity becomes important. The urine color in myoglobinuria, in hemoglobinuria, the urine color itself can tell us about the damage, or we can identify the culprit. In the microscopic examination, we should go stepwise. We should see the cells which we will see in the urine microscopy will be the tubular epithelial cells. We will see RBCs and we will see WBCs. So I will discuss in my subsequent slides what is the significance. Tubular epithelial cells is a very early insult. If you get early degree of tubular injury, you will see tubular epithelial cells which will start coming in the microscopic urine analysis. However, if the insult is established, you will get granular cast. So granular cast you get in very late stage in advanced ATN, but in early phase you should not miss, especially in liver patients, because you have to pick everything early in these patients. Epithelial cells in the urine microscopy becomes very important. Hyaline cast is okay. It is not of that much of value, but fatty cast is seen in nephrotic syndrome. Crystals can be seen in patients with renal stones or concentrated urine. And then we'll be evaluating and discussing a little more in detail about the urine albumin and the protein quantification. So this is what is important. If you see the leukocytes and you have leukocyte cast with bacteria, it is suggestive of urinary tract infection. On the other hand, if there is no bacteria and you have WBC cast and leukocytes, this is a marker of renal interstitial disease. And it is here that is important that we do a thorough drug list check and check for other systemic diseases which can cause this. Erythrocytes, if they are dysmorphic, they are almost a pointer towards a glomerular disease, and especially if they're present with the erythrocyte casts are present. The granular cast, which I already discussed, is established ATN. Eosinophiliuria is again suggestive of drug-induced interstitial nephritis. For HRS ATN, we need to see, we can see the urine. We have to initially see the clinical context. So if you have a patient with septic shock, if you have a history of nephrotoxic drug use, radio contrast, or the contrast agents have been given for doing CT contrast. So that is the clinical context, and then you can assess the microscopy. And if you have granular cast, you're almost clear that this is ATN. However, if the urine spot sodium is, you're getting a spot sodium above 40. So that mistake most of us are doing. So we should be knowing that urine spot sodium can also be high in pre-renal ATN, and it is not very clearly a marker of acute tubular necrosis. And this is a very interesting paper by Sanyal group. And what they studied here was, because we understand the pitfalls of assessing urine spot sodium, because it is influenced by diuretics, by sepsis and other such factors. So they started estimation of urine urea excretion. This is a very simple test. So what you need to do here is to quantify the urine urea and take a ratio of the urine urea with the serum urea and divide it with the urine creatinine with plasma creatinine. And what they showed here was that if you take this cutoff as 33% in their cohort of patients, the sensitivity of this for diagnosing ATN in patients with decompensated cirrhosis was almost 100%, but the specificity was 85%. So then you can use your other clinical context and other markers which can further lead you to the diagnosis of ATN in these patients. Another very simple test. So this study was again done by the American group, the TRIBE Consortium, where they enrolled 188 patients with liver disease, where they followed them up for progression or non-progression of AKI, and they studied a very commonly used biomarker. They were planning to use these biomarkers and evaluate them. And what they additionally did was also to look for serum sodium and albumin to see whether they can differentiate ATN from non-ATN. So what I've highlighted here is, we look at the biomarkers. Yes, these are expensive. If we have the facility, it is very, we can use this, but we can use a simple test like a urine albumin excretion, and we can see here in this study, they showed that this was a very important marker. It was clearly higher in patients with ATN as compared to non-ATN, could differentiate, and was not having an overlap as was seen with spot sodium evaluation. We can see there's a lot of overlap with the pre-renal azotemia as compared to ATN with spot sodium. However, the same was not noted for urine albumin excretion. And again, the area under the curve was maximal for urine NGAL, but following that, the best area under the curve for urine albumin. So if you get some albuminuria, which is not a significant albuminuria, this can be an early pointer to this patient having ATN. Urine protein to creatinine ratio is another very simple test, which if you have ruled out other forms of structural kidney damage, for instance, diabetic nephropathy and other diseases which can cause a high urine to protein creatinine ratio in a clinical context, this can also give us a diagnosis of ATN. So I'll just show some pictures and then we'll break for questions. So this is the urine microscopic pictures of patient who was having HRS AKI, and we can see here, there was some fine granular cast, and this is the evaluation of the urine. The spot sodium was 10, urine protein creatinine ratio was normal, and we can see the difference in a patient who has ACLF with ATN. This patient was deeply jaundiced, and we can see here, we can also see some bile cast in the urine. There are bilirubin crystals, renal tubular epithelial cast. So we are working on this, and these slides have been provided by this research fellow. So we're trying to see whether we can dig out as much information as possible from just a simple test, which we do not take that which we should be considering for evaluating ATN, and which can give us so much of information about coulimic nephrosis and other such problems that we see day to day in our patients with liver cirrhosis. And this is a microscopic urine analysis of a patient who had pre-renal AKI. So we can see a bland microscopic urine segment analysis. So it's very important that we go with urine microscopy, carefully observe it during the course of AKI, and which can tell us a lot about spectrum. So I'll go back to our case, and we have the microscopic urine analysis of this patient, and we see here that the microscopic urine analysis in this patient did show a lot of RBCs. They were all full field. We did dysmorphic or RBC, which was negative on both occasions. The urine albumin showed 2+. So we did a urine protein to creatinine ratio, which was also elevated. The spot sodium was on the lower side, and the urine cultures did not show any growth. The 24-hour urine quantification showed a proteinuria of 1.45 grams. The other evaluation for structural kidney damage, because considering this patient had hepatitis C, we did a complement levels, we did ANCA, cryoglobulin report is awaited. So this patient has an AKI on a background of structural kidney damage. So we can go for questions here.
Rakhi, thank you so much. Maybe we take one question and then go to the rest of the talk, and we can take all the questions at the end of it.
Okay.
Dr. Epan has some question to ask, or we go forward, or we take questions at the end of it. Dr. Rakhi, you could continue with your presentation. We take questions at the end of it. Yeah.
Okay, sir.
Perfect.
So we go on next to the assessment of AKI. And this is an emerging field. I felt it is important and it is relevant here for me to discuss a little bit about the biomarkers in clinical practice, and where do we want biomarkers in clinical practice? Do we need biomarker for every patient? In which scenario? So biomarkers are actually required for us to give us a good idea of the spectrum of AKI. So it's important for us to know what is the cause of structural kidney damage, and there is where we need a good biomarker, and we can save kidney biopsy because it's very difficult and challenging to perform that routinely in liver patient. We need a biomarker where the patient has not manifested with elevation of serum creatinine or decrease in urine output and is in the subclinical stage of AKI or is having an ongoing renal damage. We need a biomarker today to know that tomorrow my patient will have a resolution of AKI, or the patient is likely to have non-resolution, so that I'm ready with the next option and take early treatment decisions. And another biomarker is needed in patients with liver cirrhosis and who have severe stage 3 AKI, where we have to take a difficult decision of doing a dialysis or performing a dialysis in these patients. So these are the areas which I feel biomarkers are currently required with respect to liver patients. Now, we have different biomarkers that are available to us. We have biomarkers which give us the estimate of the proximal tubular injury. We have biomarkers which tell us about the glomerular injury. We have biomarkers which tell us about the distal tubular injury. And all these have been evaluated in patients with liver cirrhosis. So I go back to the same study where they performed a set of biomarkers to distinguish HRS from ATN, and they found that urine NGAL, the kidney injury molecule 1, the liver fatty acid binding protein, and the IL-18 were able to distinguish HRS from ATN. Similarly, this is the data from the European cohort. And again, just wanted to highlight urine NGAL has shown a lot of promise, and we can see here the values are clearly demarcating the presence of HRS from ATN, and this is where the problem rises. Albumin also, in their study also, I found that albumin was able to tell us, the urine albumin excretion was able to tell us and was able to differentiate HRS from ATN. This is our own experience at ILBS, and we found that this is the critically ill patients with liver disease, and we have problems of doing NGAL in these patients because it is also elevated in states of systemic inflammation and sepsis. But even though the levels were markedly higher in patients with ATN as compared to patients with HRS. Cystatin C was also showing a difference, even though it's a marker of glomerular injury, but patients with ATN were having higher cystatin C as compared to HRS. Serum angiopoietin-2 has also been recently evaluated, and angiopoietin-2 basically with the concept that when you see patients with infections, these patients most often have endothelial damage, and angiopoietin-2 is a marker of endothelial damage or endothelial inflammation. So in context of AKI, they found that the angiopoietin-2 levels could tell us whether the patient will require renal replacement therapy or not, and it was also able to differentiate HRS from ATN. So these were the two important contexts where angiopoietin-2 could have been relevant in patients with decompensated cirrhosis.
Can I interrupt you now? That we will not have much time now. So if you can go back to the important part of treatment so that we get some time at least for the questions.
Okay,
and
sir.
Maybe we might have to skip some of the slides which are probably you think less relevant at this point of time.
Okay, sir. So we'll go on to the management algorithm from here. So it's important after we have done the spectrum assessment and we have done the staging. So we need to have a good staging of the AKI, and I told you about the relevance of the urine output. And this was an important study done in patients with critically ill, and the important message which was delivered from this study of a large cohort of 3,000 patients, that almost 60% of these patients who were missed with the using serum creatinine were actually having stage 2 and 3 AKI when you considered urine output criteria. So urine output becomes very important. And it's important also when you start managing your patient to assess their course patterns during the hospital stay and see whether the patient has progression, because irrespective of these states, so a patient may present with a lower stage of AKI. If the patient has no progression, we see that the mortality is just 2%. However, if the patient has progression of AKI, the mortality is almost equivalent and almost close to patients with stage 3 AKI. So it becomes important for us to have a close monitoring and even AKI persistence. That is, if the patient does not have a resolution, even though he may not have elevation which merits progression, that also becomes important in patients, especially where your creatinine may not get high because of ACLF. Now, urine NGAL and cystatin C can tell us about whether the patient will have response or progression. And this is where we found that in HRS AKI, they can identify responders from non-responders. They can also tell us about the need of renal recovery, the renal replacement therapy, and with good accuracy and the area under the curve. And the values above 1500 for an NGAL and combining it with the cystatin above 3, we found there was an absolute risk of almost 95 to 99% in these patients requiring dialysis. However, these biomarkers were not able to tell us about the recovery of the kidney. So you need to have separate biomarkers which can tell us whether the patients will recover from the AKI have been studied. So non-recovery of AKI is an important area of investigation. Maybe we can skip these slides because this may not be much relevant. We go back to our case. So this is this whole scenario. The patient came to us, he was managed with albumin and terlipressin. Considering the diagnosis of HRS, he had resolution, and it took around 15 days. After 15 days, he again was admitted with a severe AKI, which was stage 3 this time, again required albumin and terlipressin, resolved. And the third admission was in the ICU with septic shock and ATN and AKI. And we see here the urine cast. The patient had granular cast at the time of presentation to the ICU, and there was still the ongoing proteinuria and microscopic hematuria that was seen in this patient. And the biomarkers we can see here, initially itself, when the serum creatinine was 1.2, the patient had elevated cystatin of 2.1, which was suggestive of significant renal damage. So details, if we summarize this patient had recurrent AKI, a total of 5 episodes in the last 3 to 4 months, and 3 episodes were related to AKI HRS. The last was septic shock related ATN, so the severity of AKI increased with each admission. And the patient also had some form of structural kidney damage, which we feel either could be due to IgA nephropathy, it could be due to HCV associated, or just a post-infectious glomerulonephritis, or it can be an evolution of HRS, non-AKI or HRS AKT that we are seeing in this patient. So questions which are relevant to this patient is, how do we confirm the diagnosis of kidneys short of renal biopsy, the timing of liver transplant in such a patient, when do we go for simultaneous liver kidney transplant, and how do we prevent recurrent AKI, because this patient is getting repeated AKI, and we know that repeated AKI can go to CKD. So how do we do that? So we go on to the management. In the management, it is important that we go for individualized fluid therapy. We should be using the dynamic measurements of assessment, and we should not be relying on CVP and PCWP, which were older measures. So now we have the IVC assessment. For HRS AKI, we know that continuous infusion of terlipressin along with albumin is better as compared to the bolus infusion. And while managing HRS, it is very important for us to have a target map. And because it has a close association, and the higher the map, the better is the resolution of HRS. And this is in context of patients with ACLF, where you do achieve a better response with terlipressin, but at the same time, these patients are also getting more side effects. So these patients may still require norepinephrine if they get side effects. Non-HRS AKI, we have already discussed about the drug-induced nephrotoxicity. The fluid management again becomes important, because if you overload your patient, you will having a compartment and increase intra-abdominal pressure, which itself can compromise renal function. In non-HRS AKI, due to paracentesis associated circulatory dysfunction, it is important for us to give IV albumin. And also in context of septic shock, this is the data from our center, where Abby had done this research work, and there we showed that 5% albumin could be better to crystalloids in preventing AKI and improves the micro and macro circulation in sepsis-induced hypotension. There are a lot of therapeutic strategies with respect to AKI, which are just experimental use of anti-inflammatory strategies, using plasma exchange or liver dialysis as a form of treatment modality for coulimic nephrosis is also under investigation. Dialysis is another area of debate, and it requires a lot of research in liver patients, where we should be dialyzing, how we should be dialyzing, whether we should be using dialysis as a renal replacement therapy or as a renal support therapy. All these concepts have to be studied, because what we aim to achieve is that a patient should achieve renal recovery on dialysis, and these are all important factors. If we are doing dialysis, we should be knowing, and these are important questions that are required, and this needs extensive research. And the way the AKI is evolving, and the way the management of liver patients is evolving, because we know that patients on renal replacement therapies and on CRRT are not contraindicated for liver transplant. We can still consider them if they are not oliguric and if they are having ACLF. So that's not a contraindication. Achievement of renal recovery at 6 months is the aim, as was shown in this study, that if the patient, in patients with severe alcoholic hepatitis, of the patients who required dialysis, there were 80% of these patients who died waiting for liver transplant. So many of these patients will die. They have very poor outcomes, but the patients who had renal recovery, they were successfully taken up for liver transplant, and 4 of them also underwent simultaneous liver kidney transplant. This is about the concepts of doing CRRT in patients with liver failure, because here the emergency of liver transplant is there, and the kidneys are affected by systemic inflammation. Most of these patients will require dialysis, and this is not a contraindication because you can also do intraoperative CRRT and take them up for a successful liver transplant. Management becomes important, and it is also important for us to prevent future episodes of AKI. And because we know that because prevention of AKI is important, because repeated AKI can lead to CKD. And this is an important study from our center where we looked at the hemodynamics of patients who were getting frequent AKI and CKD, and we found that low SVR, so if your patient has a low diastolic BP, which can be an indirect surrogate of a low SVR, can actually give us a lot of information. We can use albumin therapy, and this is the data from the ANSWER study, where they showed that when they gave albumin at higher dosages in cirrhotics with uncomplicated ascites, these patients get less frequent HRS. So it improves the systemic hemodynamics, and this could be an important area where we can see whether we can prevent AKI in patients with liver disease. I could get this one abstract, which was very interesting, by Dr. Praveen from Gangaram, where they showed that combining midodrine and albumin can prevent HRS AKI development. So this is an important concept of improving the severe vasodilatation with the help of albumin and combining it with vasoconstrictors. So I would like to summarize my talk with the management algorithm. The first thing which you need to do is to record the baseline serum creatinine. If you have a patient with deranged kidney function test, do an assessment, rule out chronic kidney disease or acute kidney disease which is going on, take a good history, physical examination, assess the IVC, remove all the offenders which are there, nephrotoxins, sepsis, the drugs which can cause AKI, stage your AKI based on the KDIGO staging, incorporate urine output, especially if the patient is in the ICU, give IV albumin, which should not be fixed dose based. It should be individualized patient to patient. You can add crystalloids if the patient needs more along with albumin. Then you go on to divide your patient. If the AKI is improving, you do not need to do and no need to worry. However, if your AKI is persistent or it's progressing, then it qualifies under volume non-responsive AKI. Check the urine microscopy, as I already detailed. If it qualifies, straightforward for the diagnosis of intrinsic AKI, this person needs a nephrology consultation and we need to do subsequent evaluation. If your patient has borderline urine evaluation, this patient may still have HRS AKI with some tubular dysfunction. There is where we need some biomarkers to help us know whether this patient will be benefited by vasoconstrictors. If this patient has a probable diagnosis of AKI, and this you can make by assessing the mean arterial pressure and the serum sodium. If that qualifies, you go with vasoconstrictor therapy combined with albumin, see for the response and continue till you get complete response. Go for early liver transplant. If the patient has no response, you have to go and start assessing him for kidney replacement therapy. If the patient does not have an option of liver transplant, you have to look for recurrence of AKI. You can consider IV albumin, and role of vasoconstrictors needs to be evaluated in this setting. So I summarize my talk by saying that we need to assess closely the renal reserve of each patient with liver disease who's coming to us with a derangement in the kidney function test. AKI is a very frequent and ominous complication in these patients. Use of AKI criteria is important and it has been evolving. Incorporate urine output. Urine analysis is the most basic and gives us a lot of information and roadmaps the kidney damage. Close monitoring of AKI is required for the cause to improve their outcomes. Assess the recovery even after the AKI improves. The story doesn't end there. Assess the recovery for the underlying development of acute kidney disease and chronic kidney disease. We need biomarkers. Still, most of them are experimental and we do not have hard data to support their routine use. But these are the two most emerging and encouraging biomarkers with respect to assessment of glomerular function and with respect to ruling out and diagnosing ATN. We do lack an ideal biomarker which can replace kidney biopsy like we require in our patient, which I discussed. And management protocols for cirrhotics with background chronic kidney disease have to be more defined, and we do not have any guidelines on this. Thank you.
Thank you so much, Dr. Rakhi. Dr. Epan, keep your video on. Dr. Saraswat.
I can't get my video on, Govind.
Dinesh.
Epan has some questions.
Yeah. Thank you, Rakhi. The talk was very extensive and it covered many aspects of this very important topic. There are a whole lot of questions that come in. I may touch upon a few of them. There are two, Dr. Shivanshu from Delhi and Dr. Anurag from Chandigarh have asked this question. What about HRS in cirrhosis versus HRS in a patient with ACLF? Would the treatments be similar in these two groups of patients?
Yeah, this is a very important question. And we know that HRS in ACLF is absolutely different from HRS that occurs in the patients with liver disease, with cirrhosis, because patients with ACLF have more of systemic inflammation. So as of now, the management of HRS is the same, but that's what I alluded to in my talk, that we need to explore anti-inflammatory strategies, whether we need to combine. The etiology of liver disease and ACLF becomes utmost important for us to manage. For instance, if your patient has severe alcoholic hepatitis, we have to give and go for steroid, which will also improve AKI, and it is not an absolute contraindication. And if after the patient recovers from AKI, and this area of using anti-inflammatory strategies, these patients also have background coulimic nephrosis. This is what I wanted to highlight. These are areas of research. As of now, we have to go by conventional treatment, and the recommended form of treatment would be terlipressin in continuous infusion along with albumin.
Thank you. Dr. Raghuveer from Bangalore asked the question, how does one diagnose coulimic nephropathy?
Yeah, it's very interesting because coulimic nephrosis is actually a histological diagnosis. So in a clinical perspective, where your patient is deeply jaundiced, usually it is seen in patients who have a bilirubin above 20. Most of the times they have much higher levels of serum bilirubin. And then it is mostly a histological diagnosis, but that's how, because we cannot do histology in our liver patients, we need to have some biomarker for diagnosing coulimic nephrosis. But as of now, for me, I go by a microscopic urine analysis to look for bilirubin crystals, to look for bile acid cast. If I get that in the microscopic in a clinical context, specifically in patients with ACLF, this could be a good way to diagnose coulimic nephrosis.
Two doctors, Dr. Vineet Mishra from Varanasi and Dr. Piyush Thakur from Varanasi asked the question, does one need to catheterize the patient to get urine volume study? Because you had mentioned that the urine output is one of the criteria now being included in the diagnosis of HRS. So how does one decide about the need to catheterize the patient for measuring the urine output accurately?
Yeah, that's why in my summary slide, this is another very important point, that even though they have mentioned, I had elucidated that there is a concern of routinely catheterizing patients with liver disease for monitoring urine output. That's why please don't go for catheterization to start measuring urine output. It is for patients who are very sick in the ICU, who require catheterization because they are in septic shock, or they have other complication which merits urinary catheterization. There only you follow the criteria. So that is specifically relevant in a very specific and a sick group of patients, not for all patients. For all patients, serum creatinine can give us a lot of information, and we should not be catheterizing because we'll then be predisposing them to a lot of infections.
Dr. Naveen and Gopal asked a question, is there a minimum duration of the use of diuretic or NSAID which could predispose to kidney damage?
Diuretic use is the most common cause. It is not about the duration. It is about the dosage with diuretics, and especially about the volume status of the patient. So most of the time when there is an insult in the form of sepsis, or the patient has excessive losses, or the patient has started to restrict his fluid intake, but the requirements are more, then the same diuretic in the same dose can cause AKI. This can also happen with the progression of liver disease. So it is not about, I do not feel there is any link to the duration. It is mostly to the dose that is required for an individual patient, and the reserve of the kidney based on the liver disease status. That will determine diuretic induced AKI or NSAID AKI. The patient who has a good clinical reserve, I did not have much time because these are all very important concepts. If your patient has a poor renal reserve, even a smaller insult will cause a lot of kidney damage. But at the other hand, if your kidneys are normal, even a more toxic insult will not result in that severe AKI. So that's the difference about how the kidney reserve is there. What will happen due to an inciting agent?
I'll put it the last question, after which I'll request Dr. Saraswati to take on the questions. This question is from Sri Lanka. Dr. Chatura is asking, is there a role for using N-acetylcysteine to treat HRS?
Currently, there is some data to suggest that N-acetylcysteine could be helpful as an anti-inflammatory agent. There is some data for N-acetylcysteine with respect to preventing contrast-induced nephropathy, so it counteracts the reactive oxygen stress. And the other the ischemia reperfusion into that happens in patients with kidney disease. So that's the mechanism. So in patients with inflammation-induced AKI, it could be an attractive option. If you have paracetamol-related kidney damage, it could be an attractive option. I, as a person, personally, I use it for patients with alcohol-related ACLF in the ICU who have kidney injury. But as such, there is no guideline or no recommendation. There is no study which suggests us to use that.
Right. I think, Rakhi, you have a very extensive review. And I think a lot of questions, I think over 175 questions have come in, and we've barely asked you 5 or 6 of them. I'll also try and cover about 4 or 5 questions in the next few minutes, and then there'll be a lot of homework for you. Okay. Right. I think the question that I have are more related to the diagnosis of HRS and the test that I used. The one that I have regarding therapy is, I think, the timing of terlipressin introduction in a patient with HRS. The older guidelines talked about waiting 48 hours, topping up the volume with a predefined volume of serum of albumin infusions, and then if not improved after stopping diuretics and so on, then start terlipressin. Has this concept changed, or you would still need to wait 48 hours even if the patient's volume, when he presents to you, may actually be topped up? They have been in other hospitals, and the volume and the CVP, IVC measurements tell you volume is topped up. So should you start with terlipressin on day 1, or wait for 48 hours volume replacement and then start terlipressin albumin? What do you think?
So I feel, again, guidelines suggest us to wait 48 hours, but I totally do not believe that concept that we have to fix ourselves waiting for 48 hours. It depends on the clinical context. So if I'm managing a patient as in the patient is in the ward and he presents to me with AKI HRS like this patient had presented, he already has a history of AKI HRS in the past. So there's a very high chance, and on a background of refractory ascites and hydrothorax, we have to have a low threshold. So that's why monitoring for response is very important. If my patient, if I do not have any obvious insult which has led to pre-renal insult to the kidneys after initial volume resuscitation, the patient, if they are not improving, we have to start early terlipressin, especially if the patient is not improving, we need not wait for 48 hours. If I talk about intensive care unit, we do monitoring of the urine output. So if the urine output is not improving, and if you see that you've done your resuscitation well, you've done your dynamic assessment, your volume status is well handled, and despite that, your patient metabolic parameters of kidney functions, your urine output is not improving, we will never wait for the patient to for 48 hours. So these guidelines need revision. And in a clinical context, we should see and start early terlipressin rather than waiting.
If the volume is topped up, don't wait, and the kidney function not improving, start early. That's what fluid would you use? Was another question was, when there is pre-renal AKI, what fluid should be used to restore volume? Because you're always afraid of ascites worsening if a lot of sodium or saline is used. What are your thoughts on that?
So this is also a very important point. So a patient, it's not that they may get ascites. So if my patient who was having refractory ascites, supposing grade 2 or 3 ascites, and has gone to a state where he's not having ascites now, and he's presented to me with stage 2 or 3 AKI, there I will not be worrying about just giving 1 gram per kg albumin. I will give aggressive volume resuscitation to this patient. I will give a lot of crystalloids also to the albumin, because albumin adds too much to the cost of the patient. We cannot give too much of albumin. On the same hand, if I have a patient with cirrhosis who's presented to me with ascites, which is there, he has AKI on top of ascites, he already has grade 2 to 3 ascites, he has significant kidney injury, I should be worried, because here, if I pump in too much of fluid, so here we should be very cautious in this scenario, give cautiously, assess dynamically, and give albumin initially. And if the patient has response, we can go forward. If the patient has presented to us with septic shock, obviously we have to go forward with a different form of albumin. We will not go with 20% albumin in that setting.
Right. Regarding the use of urinary NGAL, you covered it quite extensively in your talk. So you're using NGAL quite often is one question that has been asked by Dr. Piyush Thakur from Varanasi. How often do you feel the need to use urinary NGAL to differentiate AKI from ATN? And similarly for urinary NGAL, I think the other question is its role in the differentiation of HRS AKI versus ATN. What would you say?
Urine NGAL is something which we have now started routinely in our clinical practice. And this is only in the intensive care unit. We're not using in the other OPD or outpatient, because there it may just not give us what we need to ask from urine NGAL. In this area where we do NGAL is where we want to have a differentiating. A patient has come to us with very severe AKI. He meets all parameters for dialysis. I don't want to dialyze this patient. I would like to wait in a cirrhotic, but waiting also is very disastrous. So we have a very thin line when to dialyze these patients. So what we do as a protocol is we resuscitate them well. We send their urinary biomarkers. We see their evolution of the course with volume resuscitation, because ATN patients, if you give, you have to be very careful about your volumes, and you can harm an ATN patient by giving too much of volume. So here, after we've done and we are in a state where we are not able to make our decision, there the urinary biomarker will give us a lot of information, because if the value is above 1500, most of the times it is important, and we know that the patient is heading towards dialysis, and we should not be waiting unnecessarily for the kidneys to respond.
Right. I think Dr. Ajay Kumar from Rishikesh also had a similar question about initiation of dialysis in people with AKI at a relatively earlier stage before they meet your standard criteria of volume overload, acidosis, or hyperkalemia, and so on. You know that we are all familiar that in ALF, we tend to start some kind of renal replacement therapy quite early to tackle the ammonia. So in the setting of ACLF or AKI, do you consider initiating dialysis even before the classical criteria for dialysis are met? How do you go about it?
So the AKI perspective in liver, I would again stratify in two parts. One is a patient where there is HRS. The patient we managed as HRS, and now he's slowly progressing. He's not responding and slowly progressing towards dialysis or ATN. This patient has not met absolute criteria. There is no harm in waiting in such patients. We should rather be waiting for HRS patients who are meeting relative criteria for dialysis. Where we should not be wasting time is the context of septic shock, especially if the patient has acute and chronic liver failure. These patients are already systemically vasodilated. When they present to us with septic shock, they are more vasodilated. And after the initial fluid resuscitation, the best time is to dialyze them early rather than waiting for their hemodynamics to crash, because then they rapidly go down. So that context where the patient has severe infection, severe sepsis or septic shock with hypotension, there I would like to do the dialysis early on after a proper well fluid resuscitation. And then I use all my guidance of volume assessment and everything to make sure that I do not harm these patients by doing an unnecessary dialysis.
Okay. I think a couple of quick questions about the diagnostics also. You've talked a lot about eGFR, and in the early part of your talk about assessing severity by various formulae for eGFR. So Dr. Achal from Bangalore and Dr. Lohit from Bangalore also wanted to know, is there any difference? Which is the best formula to use? Is MDRD better than Cockcroft-Gault or other various? I think there are 3 or 4, the EPI, CKD EPI formulae. So which one do you recommend would be a good one for AKI in cirrhosis?
I have a lot of experience, sir, here with the MDRD6 equation, and I feel it correlates well with the cystatin C. As a matter of fact, now, because I have published so much on cystatin C, and I firmly believe that cystatin C gives us a lot of information about the glomerular and the renal functional reserve of the patient. So even if the patient has normal renal functions and has ascites, if you do a cystatin C in these patients, so the value of cystatin C based equations, if we compare with MDRD6, there is a lot of differences. What I see in my clinical practice in the outpatient is there is almost a difference of 10 to 20. So cystatin C based equation give us a lower GFR. So everybody would qualify as CKD. So it's difficult for me to say, but MDRD6 gives us a lot of good information. Now, I also discussed about two new formulas that have recently been published, the Mendiclo and the Grail equation, but I have personally no experience of using them.
So as of now, MDRD6 is actually being quite widely used. One would recommend those. In the CKD and the renal population, I think CKD epi is generally more popular. But for liver cirrhosis and the AKI, I think MDRD6 would be a good equation to go with.
But we get very different values. If you put all equations in the same patient, you will see that there will be a difference of around 10 to 15 ml. For every equation, there is a difference. So it's very, very difficult to say how we are measuring GFR. But if we follow a uniform protocol, I feel MDRD6 is a good equation. If at all cystatin C, creatinine, both CKD EPI equation is something which we can use, incorporating both cystatin C and
creatinine. I think many people do not really have access to cystatin C and GAL, etc. They are not widely available. So there are some of the older tests that people are following, like BUN to creatinine ratio, the fractional excretion of sodium, and then the urine routine microscopy. You showed some nice slides. How sensitive would urine routine microscopy would be in differentiating HRS from ATN is one question that Dr. Arun Singh from Indore has asked. And the other one's about the FENA and the BUN to creatinine ratio. What are your thoughts on those older tests?
Urine analysis, I feel, is a very, very important test, and we are not carefully seeing that much in our liver patients, but we can actually use this test to give us so much information about the kidneys in the liver patient. And if I talk about urine test to say whether the patient has ATN, a very simple test which can tell us albumin excretion. And if you've ruled out a background chronic kidney disease, you have ruled out a glomerular injury, a cause for glomerular damage, because albumin usually is a marker of glomerular injury. So it is very important in that clinical context, if you're trying to think whether the patient has ATN and you have ruled out urinary tract infection, urine albumin excretion has been shown by all studies now, albumin to creatinine ratio, protein to creatinine ratio, urine albumin is a very sensitive and a good marker of an underlying tubular dysfunction or maybe a glomerular injury to the patient.
Okay, I think there are several more questions. As we have been talking, the number of question count has crossed 220, but I don't think the time will permit us now. We are 20 minutes past 6. So I'll request Dr. Govind to kindly take over and take us through the last stages of this talk. Govind, please.
Dr. Rakhi is a wonderful talk, and with every minute passing time, we get one more question. So we have now 220 questions, but I just want a question on Facebook Live also. Dr. Samsir Singh asked a question. If albumin is not available, what is the best fluid?
If albumin is not available, I feel the liver patient is at pity, but yes, we can use crystalloids, and you try and use more of plasma in those patients, because you need to give some form of protein to these patients are hypoalbuminemic. They have interstitial edema. Crystalloids, we use balanced crystalloids. Plasma light is a good option, but I feel that albumin is required. We should not.
And the last question from your own institution, from ILBS. When do you say that terlipressin is unresponsive? A patient is unresponsive to terlipressin. When do you say that? Short answer, please.
Terlipressin, sir, I want, because when we give terlipressin, I see immediate effects. If I'm seeing urine output as the criteria, I start seeing improvement in urine output. If I see other biochemical indices of kidney injury, that gets improved. If I'm monitoring a stable patient with creatinine, I would say that the creatinine has started to decrease. Overall improvement in urine output and kidney function parameters is, for me, the patient has started to have a response. Now, whether this is partial or complete in the end, that is another decision. But that will tell me that patient has started to respond.
And Dr. Katie Sonoy compliments your lecture, and he has sent his best wishes to you. Thank you, Dr. Rakhi Maiwall, for a wonderful, wonderful talk. It's a difficult topic, but again, you took us through the new definitions and protocol for management. I think all of us have learned from you. Thank you. Thank you so very much. Keep rising, keep doing good work. You are doing so wonderful work in hepatology field.
Thank you, sir.
Thank you, Dr. Epan, for agreeing to moderate this session. Thank you so much. And thank you, Dr. Saraswat, for, again, all your support to ISG Masterclass. But before we close, two things one is invitation, that we have a next lecture coming on this Sunday from 12 to 1. And this is again, important topic, that how do you treat your patient with Crohn's disease? And for that, we have again, the master to take this lecture is Dr. Vineet Ahuja. He's a professor of gastroenterology at AIIMS, New Delhi, and his work in the IBD is exemplary. So it will be a treat to listen to him on this Sunday, 12 to 1, that is May 10. And lastly, that please do respond to the questionnaire we are going to send to you right away after this lecture. We need your feedback so that we can improve the quality and value of these classes. Thank you very much. Thank you, everyone. Thank you, viewers. Seeing on Facebook and seeing on Masterclass. And we see you on the other side on Sunday at 12 o'clock. Good evening, everyone.
Bye-bye, everyone. See you.
Okay, sir. Bye.